Good afternoon and welcome to the spring 2015. It really is spring, honestly. The spring 2015 Presidential Lecture Series. My name is Diane Call. I have the privilege of serving as the president of Queensborough Community College, and I welcome each and every one of you to our college campus today and to this event, which was essentially established about 15 years ago by my predecessor. And the focus for the spring lecture, it really does feature our own faculty, and we have a wonderful array from whom to select, and we are exceedingly grateful to our Presidential Lecture Committee for its work to identify a very hard decision among all of our faculty who might present a lecture for the spring. So I'd like to thank the members of the Presidential Lecture Committee, Dr. Sasan Karimi, from chemistry himself, a presidential lecturer, Dr. Karen Steele, Dr. Amy Traver, and Dr. Mark Van Els. And I thank them for their work, and again, I welcome you to this lecture. Emerging Trends in Healthcare, a very interesting topic for this time. Professor Mary Ann Rosa is with our nursing department. She's a gerontological nurse practitioner and a consultant for North Shore, Long Island Jewish Health System, and she serves on a task force charged with decreasing readmissions and improving health outcomes, something we all aspire to, no doubt. In 2000, Professor Rosa was inducted into the Nursing Center of Excellence of LIU for her work in community health care. And we were very, very happy that she was able to join our faculty a number of years ago. Along the way, Professor Rosa developed a heart failure community disease management health program and another community health program to manage diabetes. At Queensborough, and we pride ourselves on the quality, the excellence of our nursing program, our nursing faculty, and our students who are outstanding. At Queensborough, Professor Rosa implemented telehealth into our nursing program, a very rigorous program to begin with. And she assisted with the incorporation of this concept at several other CUNY schools. Patient-centered care using technology as part of a health management system is really at the forefront of our efforts to design health management programs to increase life expectancy while decreasing the costs, which obviously are everyone's concerns. I'm very anxious to hear her discussion of emerging health trends, particularly in light of the fact that we have an ongoing conversation about healthcare in this country and the use of technology. Professor Rosa, please join us.
Thank you. I'm honored and privileged to be here with all of you this afternoon, and I would just like to thank President Call and the Presidential Lecture Committee for this opportunity. I will be discussing emerging trends in healthcare. So I will focus on an aging America and the increase in chronic illnesses and the impact that has had on our health system. I will then focus on some national initiatives and advances in technology that have decreased costs and have improved healthcare outcomes. So because we have an aging population, we see more chronic illnesses. And when we see more chronic illnesses, we see people in the community with increased healthcare needs. And then we happen to see more hospitalizations and more hospital days. So frequent hospitalizations make patients weaker. They may have been able to self-manage their illness before a hospitalization, but when someone is hospitalized, they can have new impairments and new disabilities. And that could be in some of their basic needs like nutrition and sleep and activity. Also, when patients are discharged from the hospital, very often they have some degree of cognitive impairment. And that can interfere with their self-care ability. They may find it hard to get organized, or they may be a little confused over the treatment. And very often patients are also on multiple medications, which is another factor that can impact on their self-care ability. The older someone is, and the longer the hospital stay, the more at risk they are for a readmission. And this cycle of frequent hospitalizations makes patients frail and vulnerable. So demographic changes have created an urgent need across our country. And here's some statistics for you. By 2030, 1 in 5 Americans will be an older adult. An older adult is anybody over the age of 65, and that will be about 72 million people. By 2050, the number of people is expected to double what it was in 2010 for the older population. For the 85-plus group, that is expected to triple. And this is happening because people are living longer, and we also have aging baby boomers, and those are people born between 1945 and 1964. So the baby boomers, they really have impacted across our country at every aspect of their lifespan. So we've seen different things occur throughout the years. We've seen sales of baby food rise, commercial baby food. We've seen construction of schools and housing rise. But the biggest impact has been on our nation's public health and social services and healthcare system. And our healthcare system is forced to address the needs of an aging population. So years ago, the leading indicators for death, or the health indicators for death, were infections and acute illnesses like tuberculosis. And while we still may see some of those illnesses today, we don't see it as much because of the advances in medical treatment. But what has replaced those illnesses as the leading causes of death have been chronic illnesses like heart disease and diabetes, chronic lung conditions, and cancer. Half of all older adults have one or more chronic health problems. 1 in 4 adults have more than one chronic illness. In fact, patients with diabetes, 10% of those patients have just diabetes. The other 90% have other comorbidities in addition to the diabetes. And when patients have multiple chronic illnesses, this increases the need for specialists and treatments and medications. And medications for one illness that are good for one illness might adversely affect another illness. They may also be at risk for redundant tests and possibly avoidable hospitalizations. So now, longevity increases our risk for chronic illnesses. Genetics may play a role. About half of American adults have at least one major risk factor for heart attack or stroke, and that would be hypertension or high cholesterol or being a current smoker. About 90% of Americans consume too much sodium or salt, and this increases the risk of high blood pressure, which is a risk factor for heart disease, heart failure, stroke. 1/3 of all Americans have obesity, and obesity also contributes to these chronic illnesses. Obesity, in fact, is one of the strongest risk factors for hypertension. So while getting older and genetics we cannot modify, we can modify our lifestyle, which also can contribute to chronic illnesses. So if you look at the plate size, years ago, it used to be a 9-inch plate, and today it's a 12-inch plate. So what does that mean? More calories and more food, more saturated fat possibly. I encourage you to use a 9-inch plate. It'll look like you have more food as well. Years ago, popcorn, we used to be satisfied a little container. Today we get a tub of popcorn, extra butter, so we're piling on, again, saturated fat and calories. Coffee. Years ago, we were satisfied with a small cup of coffee, but now we get extra large and we top it with extra toppings like whipped cream. And again, that could be 8 times the amount of calories that we're consuming. Now, while this is not a healthy choice, if you look at years ago, the same meal was about 400 calories. But now with the supersize phenomenon, that same meal is about 1,400 calories. That's almost the total amount that we should have for 24 hours, almost. And what's wrong with this picture? Now, in all seriousness, these people could have joint problems, and they could be going to do water aerobics, which is fine, right? But it kind of just highlights the sedentary nature of our society. So chronic illnesses and diseases are defined by the World Health Organization as illnesses that are permanent, leave some form of disability, and require training, specific training by the patient, and also require a period of observation and supervision from a healthcare team. And when patients have chronic illnesses, they may not be feeling well, so it makes it harder to self-manage the illnesses. And so learning is harder, working is harder. They may even experience diminished functionality or decreased quality of life. It could interfere in their activities of daily living. And then we can see an increase in institutionalized days, whether that be in a hospital or a skilled nursing facility. So interventions really should begin early in life. Our younger population will be old someday, and also in our younger population, type 2 diabetes is an epidemic among our younger population. So interventions should really begin earlier. And communities are pivotal in creating environments that help people to make healthy choices and live a healthy lifestyle, which not only includes healthy eating, but activity. And it's very important to keep people functional. So when patients are coming out of the hospital, a lot of times we're focused on therapy and medications and treatments, but we don't want to forget about keeping functional and active. Evidence tells us that the more functional we keep patients after a hospitalization, the less likely they ought to go back. So chronic illnesses not only impact the activities of people and how well they feel, but it also impacts on cost, right? So more than 2/3 of all healthcare costs are for treating chronic illnesses. And in our older population, 95% for chronic illnesses. So for people over 65, it costs 3 to 5 times higher than the care for people younger than 65. So we see this shift from acute care to chronic care because of the rise in chronic illnesses. And individuals are discharged from the hospitals quicker and sicker, so the needs increase in the community. So self-management becomes very important. And this starts in the hospital, and it has to start in the hospital, but there are some obstacles. Patients may not be feeling well. The environment may not be conducive to learning, so it has to continue in the community. And there's some advantages to that. The patient is in their own environment where they feel comfortable, they feel in charge, and we uncover positive as well as negative factors that may impact on their self-care ability. So we have to look at the hospitalization rates. Nationally, 30-day readmission rates from patients that are discharged from the hospital are about 18 to 23%. And this is for the age group 65 and older with chronic illnesses. It was about 25% for many years, and over the last several years, it's come down a little bit. The 15-day readmission rate is about 13%. So this is telling us that when patients come out of the hospital, they are frail and they do have needs that need to be met. This also increased costs for Medicare. The Institute of Medicine says that this is possibly an indicator of poor care or missed opportunities to better coordinate care when we see frequent hospitalizations like that. One study in the New England Journal of Medicine says that 76% of these rehospitalizations are preventable. About 30% for our older adults are due to non-adherence. So this further highlights the importance of these self-management programs. And evidence tells us that with intensive management, we can decrease these avoidable readmissions. So one national initiative that's going on right now is the Hospital Readmission Reduction Program. And Medicare is authorized to give decreased reimbursement to hospitals that have frequent readmissions within 30 days. Now, this started with the diagnoses of heart failure, heart attack, pneumonia, and several other diagnoses have been now included in that. And it's all cause. So if a patient comes out of the hospital and they had heart failure, but they get rehospitalized maybe for an infectious process, the hospital still gets penalized. So this has a ripple effect on the community. Hospitals want to align themselves with community-based agencies or healthcare agencies that are going to help them keep patients well and keep them out of the hospital. I like this article that was written by Atul Gawande. He's a Harvard graduate, he's a surgeon and an author, and he wrote the article, The Bell Curve. And what he talks about is that some hospitals do very well, some hospitals don't do so well, and some hospitals cluster around the middle. And this is what creates the bell curve. So he goes on to tell the story about a young girl named Annie. And she had cystic fibrosis. And cystic fibrosis is an illness where the secretions in the body thicken. So it can clog airways in the lungs, and it can clog the digestive tract. And she was being seen at a hospital that wasn't doing so well with their clinical outcomes for cystic fibrosis. And the physicians there decided to be transparent with Annie and her parents and tell them, we're not doing very well with our clinical outcomes. And they gave them the name of the hospital that was #1 in the care of cystic fibrosis. But they also went on to tell them that we are going to do whatever we can to improve those clinical outcomes. So Annie and her parents felt comfortable staying with them because they were so transparent with them. And today, our hospitals, he spoke about this in 2004, and today our hospitals are very transparent. And we can get this information at Medicare.gov. And we can get report cards on how well nursing facilities are doing, hospitals are doing, home care agencies are doing. He also went on to say, will hospitals get paid for performing better? And again, this is in 2004, but that's exactly what's happening now, and I'll talk about that. So the staff at this hospital that was not doing very well with the clinical outcomes for cystic fibrosis went over to visit the hospital that was. And they expected to find some new treatment or new medication that they were giving to their patients, and they thought maybe that's why the outcomes were so much better. But when they went there, they were surprised because they were adhering to the same standards of care and the same guidelines that they were adhering to. What was different is that the physicians were spending more time with the patients, and they were asking questions like, how are we falling short of helping you? What can we do to make you feel better? What makes it hard for you to follow the treatment plan? So they were making it patient-centered. They were using the skills of motivational interviewing, which is a skillful way of counseling to facilitate these productive conversations, to keep it patient-centered. And that's very much a part of all the programs today. So the point is that knowledge alone and guidelines alone, while they're very important and we do have to adhere to best practices and standards of care, it's not the only thing. There's much more than that. So chronic illnesses doesn't have to mean that someone will become debilitated. Getting older doesn't have to mean that someone will be disabled. With care, proper care, a lot of complications and associated conditions can be delayed or prevented. So self-management programs, disease management programs, they're at the forefront of helping people manage their illnesses. So they help patients transition from the hospital to the community, but they also help patients that are already in the community. So they want to help patients not only when they're ill and not feeling well, but when they're healthy. And they want to help patients stay healthy and empower patients. The HEDIS measures, that stands for Healthcare Effectiveness Data and Information Set. That's a set of measures that many healthcare plans use, a lot of disease management programs use. And what that is, it helps agencies and to make sure that they're adhering to the standards of care. So for example, if a patient had heart failure, they would look at such things, well, are they on the right medications? Did they have an ejection fraction done, which is a measurement of how well the heart is functioning? If they had diabetes, are they getting the proper annual screening? Did they have an A1C done, which is a blood test that measures the glucose over a longer period of time? In fact, now, community-based organizations will not get reimbursed unless they have an A1C documented every 3 to 6 months. So disease health management. Stan Bernard, consultant to the Department of Health and Human Services and the Heart Failure Society of America, defines disease management as a set of measures to improve clinical outcomes and decrease cost. But Stan Bernard went on to say, why do we call it disease management? Why can't we call it comprehensive health management? I agree. The word is more positive. So when I first developed the heart failure program, I had a patient come up to me and said, why do you call it the heart failure program? Why can't you call it the heart success program? And I thought that was such a great idea. So I changed all the names to the heart success program, but I got in trouble because I was confusing patients. So the hospital called it one thing, we were calling it another. So I did have to change the names back. But years later, today, they do use more positive terms. So you hear such programs as the Diabetes Wellness Program, the Heart Healthy Program. So we do see positive terms being used. Because again, we want to focus on when patients are healthy and keeping them healthy as well. There are some national programs going on to promote health. We have the Healthy Brain Initiative, and that came about by the CDC because of the increase in Alzheimer's disease and cognitive impairments. And what that does is it helps healthcare facilities promote cognitive health, and it also looks into the community to help people that have cognitive impairments and help their families. A Million Hearts, that was started in 2011 by CMS and the CDC, and that is an initiative to prevent 1 million heart attacks and strokes. And they do that in ways by smoke-free environments, decreasing the amount of salt in food, eliminating trans fat. Healthy People 2020, another set of national objectives. This is done every 10 years, and it's a set of objectives, again, to promote health, and it focuses on maybe illnesses that we see that are more prevalent. And in 2010, we did see some positive outcomes. However, we still need some more work with decreasing health disparities and decreasing obesity. And I'd like to also highlight some healthy initiatives that are going on at CUNY and Queensborough to promote a healthy environment, tobacco-free environment, the promotion of healthy eating. There's wellness festivals, there's screenings. So if you work here or go to school here, I encourage you to take part in these programs. Health literacy is another national initiative. And this is defined as not only patients being able to find that information and understand that information, but also to process that information to make appropriate health decisions. And many people, 9 out of 10 older adults, have trouble carrying out information, following information, because it's not easy to understand. It's often not written from the patient's point of view. And when this happens, they have difficulty then managing their illnesses. If you look at this study, show me how many pills you would take in one day. Patients with low literacy, 71%, said, yes, I understand. But only 38% were able to demonstrate understanding. So this just highlights the importance of making sure information is understandable to patients. Now, the instructions on this label are take 2 tablets by mouth twice daily. Sometimes patients feel they took 1 in the morning and 1 in the evening, and they feel they took their 2 tablets for the day, when it's really 2 tablets twice a day. So this national initiative is not only looking at the skills of the patient, but is also focusing on the skills of the healthcare professional and what the professionals and the organizations are doing to have this information user-friendly for the patient and understandable for the patient. So each organization has to have a health literacy plan, and each organization has a committee. So if the health team develops any material, it has to go through that committee so that they can approve this material. Healthy People 2020 is tracking health literacy improvement, and the CDC also has online resources. Some other national initiatives going on right now. One has to do with ICD coding. So coding identifies an illness. It's a set of numbers and letters that identify illnesses, procedures, and it gives us information. It gives us information on statistics, on illnesses that are more prevalent in certain areas. It also gives information to health companies, insurance companies, for reimbursement. So right now we use ICD-9 coding, but the United States is the only industrialized country to still use ICD-9, but we're changing over to ICD-10 by October of this year. So now the codes are about 3 to 5 characters. It will change to 3 to 7 characters. And we have now 16,000 codes. We will have 70,000 codes so that we can be more specific with illnesses, and it'll decrease any errors and any claims. Other initiatives that are going on, one has to do with observation units. So instead of patients getting rehospitalized, they may be observed for a period of time in the hospital. And this could be 24 to 48 hours, but they're not admitted, they're observed. So if they have interdisciplinary teams in place and they're following specific protocols, this may be very good for the patient because we don't have a hospitalization and we don't have the risk of patients becoming debilitated. So it may be a good thing, but the only time it can become worrisome is if the patient needs extended rehab after that time period, because they won't be reimbursed for that because they didn't have the 3-day qualifying hospital stay. So that could be an issue. Improvements in transitional care. We're seeing that across the country. And this is really important because we want patients to stay healthy. We want to avoid those avoidable hospitalizations. One of the first things is making sure patients are appropriate for discharge. So we do have teams of people in the hospital that work on this. We have discharge planners. But one of the problems we've seen across the country is the breakdown in communication. The breakdown in communication from the discharge planner, getting the information from maybe the hospitalist to the community physician or the community home care agency. So there's initiatives across our country to improve that. And any patient has the right to appeal a discharge also, because if patients are discharged too quick and not to the right setting, of course that would increase the likelihood of an avoidable readmission. The other thing about discharge planning that they're working on across the country and in some of our own area hospitals is medications. Medications is a leading cause of readmission with patients, and they're finding that when patients go home, sometimes there's a couple of days they may not fill very important prescriptions, or it may be a weekend and they don't have access to fill those prescriptions. So what the hospitals are looking at now is trying to give patients a 48-hour supply of medications, or looking at their internal pharmacies to maybe fill prescriptions before a person leaves the hospital. The other thing, social workers are teaming up from community to, well, from hospital to community to identify pharmacies in the community that will pick up prescriptions and then deliver the medications to patients so patients don't miss out on very needed medications. The other thing that they're working on is transportation. After the patient leaves the hospital, evidence tells us that if the patients don't see their healthcare provider within 7 days, they are more likely to go back to the hospital. So it's very important to have that continuity. So they are working on that because insurance companies don't cover transportation. Not all insurance companies cover transportation. So they're trying to work on that as well. So they can connect patients quicker to their healthcare providers in the community. So as you can see, it forces hospitals and community agencies to work together. So that alone improves transitional care. Another national initiative going on has to do with the Affordable Care Act, implementing different payment and delivery systems. And one of them is accountable care organizations, and that has to do with different providers connecting and working together to improve clinical outcomes. Patient-centered medical home models, that's where a patient is assigned a care navigator or a care coordinator, and that person follows the patient from hospital to community. So it decreases any fragmented care that can occur because they can really catch anything that can be missed because they're following the patient. And they're a link between all the physicians from the hospital to the community. So pay for performance. This is what Atul Gawande was talking about. And now our hospital is being rewarded for improving care instead of quantity. So years ago it used to be fee for service and they would get rewarded for quantity, but today they're getting rewarded for quality. So I know there is some controversy with the Affordable Care Act today, and I'm not sure where it will go moving forward, but I hope some of the positive things that have come about remain. Another initiative, the Bundle Payment for Care Improvement Initiative, this is an initiative that is based on episodic time periods. And there's a lump sum given for a certain period of time, and that could be 30 days, 60 days, 90 days. And there's a couple different models of this. One model gives a lump sum for community, for hospital to community. And again, the hospital and community have to learn how to work together because they're getting one lump sum payment to keep the patient out of the hospital. So they work across healthcare settings. So preliminary findings have told us that we do see improved care and we do see decreased readmissions. So technology, does it save money or increase costs? Maybe a little bit of both, but it really depends on the type, how it's utilized. Is it appropriate? I'm going to focus on some of the types of technology that do improve clinical outcomes and decrease costs. Smartphone technology. That's beneficial for clinicians and it's also beneficial for patients. There's a lot of apps that are very helpful to all of us. Here in the nursing program, we use Unbound Medicine, and that connects us to drug guides and medical information. There's an app called Fitbit. You should all download it on your phones. It helps us to keep on track with healthy eating and activity. There's certain apps for patients that have chronic illnesses like diabetes to help with carb counting. The only thing I would encourage is that if you're looking to download any apps, just make sure it's accurate information. And how would you know that an app is okay to use is, for example, if you had diabetes, go to the American Diabetes Association, and they recommend certain apps that are accurate. Electronic health records, that has done a lot for our nation so far. It has decreased errors, it's a means of communication, it's improved clinical decision support, electronic prescribing makes it easier for the providers, for the patients. Patients have accessibility to some of their records, but there has been some challenges with the electronic health records, especially during the transition period of when institutions are transitioning from paper to computer. That can be quite challenging. And the challenge of adhering to best practices and privacy and making sure the information is accurate. Sometimes fields in the computer can auto-populate, so it's up to the professional to make sure that that information is correct. But I would also urge everyone to make sure if they have an electronic record popping up that it's correct. For example, you have all your information on an electronic record, you go into an emergency room, all your medications pop up. You want to make sure it's accurate, though, that you didn't go to someone that didn't enter it into that record because you don't want to get medications that maybe you shouldn't be getting. The other challenge has been patients perceive sometimes the computer as a barrier to the provider-patient relationship. So that's a work in progress to not decrease that relationship, not interfere with that patient-provider relationship, because sometimes it may feel that way. CardioMEMS. This is for patients that have heart failure. This was just FDA approved last year. This device, it's about the size of a paper clip, and it's placed in the pulmonary artery through the way of the femoral artery. And it measures pressures in the lungs. And what this does is, sometimes patients with heart failure have fluid retention and shortness of breath, but this will identify a problem before that occurs. So before a patient would get the shortness of breath and the swelling, this will tell us that something's wrong. And then medications can be adjusted accordingly. It has decreased readmissions for heart failure by 37% and very few complications. I know of 2 hospitals that are doing this now. North Shore, Manhasset, and also NYU in Manhattan are using the CardioMEMS with very good results. This is a life vest. This is a wearable defibrillator. So sometimes patients have internal defibrillators if they're at risk for life-threatening arrhythmias, but sometimes the internal defibrillator can become infected, or they're waiting for the internal defibrillator, so they may get a life vest instead, temporarily maybe. And this, what this does is there's electrodes placed on the chest, and the heart is monitored continuously. And if a life-threatening arrhythmia is detected, this will shock the patient, and it will shock them into a normal heart rhythm. This is worn 24 hours. It's just taken off to shower. This is an LVAD. This is a left ventricular assist device. Some patients with advanced heart failure may need this, and this is surgically implanted into the abdomen, and a drive line comes out, and it's connected to a machine that helps to pump the heart. And it's implanted in the abdomen, but it also connects to the heart to assist the heart in pumping. And sometimes patients need this temporarily while they're waiting for a transplant, or sometimes patients have a type of heart failure where they will recover, but they need some help temporarily. It's also being looked at for destination therapy because it does extend life, and it also improves quality of life. This is a gastric pacemaker, similar to a cardiac pacemaker. And it's done by a minimally invasive procedure, and wires go to the stomach, and it treats a condition called gastroparesis. Gastroparesis is a slowing down of the stomach from emptying into the small intestine. And that happens because of illnesses such as diabetes and nervous system disorders. So this gastric pacer can stimulate the stomach muscles and stimulate the nerves so that the stomach doesn't slow down. Okay? And then it can decrease those manifestations that they get, like nausea and vomiting and abdominal pain. So it can really help patients to feel better. This is continuous glucose monitoring. So for patients that have diabetes, that have glucose that may not be stable, this may be an option. And what this is, it's a sensor that's inserted under the skin, and it checks the glucose levels in tissue fluid. And it can check it very frequently at 1 minute, 5 minute intervals. So it also can alert the patient that the levels are going too low or too high. And it can be sent to the computer for tracking and analysis. So the thing about this, though, it's tissue fluid, so it's not as accurate as blood. So if a very high reading occurs or a very low reading occurs, patients are still encouraged to check it by the regular glucometer. These are smart pill bottles. If you can see here, it's lighting up blue. That reminds a patient to take their medication. So this is very helpful for people that are forgetful in taking their medications. If they miss a dose, it will light up in red, and it will also beep. Okay? It also gives information when the bottle was opened, how many pills were taken out, when the bottle was closed. And this information can be sent to the patient, to a family member, to the clinicians, providers. And now they're also looking at smart pills themselves, because even though the patient took the medication out of the bottle, no guarantee that they actually took the medication. So smart pills, they have a sensor actually on the pills, and when it comes in contact with gastric fluid, it sends a code. And it tells us that the patient took this medication and took a specific dose of that medication. Now we get to telehealth, and there's an explosion of telehealth across the country. It is defined as the use of technology to deliver healthcare, information, or education at a distance. The Affordable Care Act addresses telehealth as a means of delivering efficient and effective health care. It affects global health, it affects population health. There's two types of telehealth. And if you've ever spoken to your physician or your nurse over the phone, or if you're a clinician and you ever spoke to a patient over the phone, you've done telehealth. It's been around for years, but it's just that technology has changed through the years, so we're able to do a lot more with it. So there's two types of telehealth. One is store and forward, and that's where patients will take a set of vital signs, they'll answer some questions, and then that information gets sent over to the clinician's computer. And then there's real-time communication, where we can connect with the patient through video interaction. So the patient sees the clinician, and the clinician sees the patient. There's many studies that have been done through the years to show that telehealth has improved clinical outcomes and has decreased cost. I was involved with a study in the late 90s, early 2000s with LIJ and Bass Stony Brook, where we introduced the monitoring portion of telehealth, and we saw that we did decrease readmissions, and then soon after that implemented the video component of telehealth. So that real-time video component of telehealth gives information when you need it, when the patient needs it. So if a patient doesn't feel well, if they have chest pain, they can call up and say, I don't feel well, and we can connect with that patient immediately and do an assessment and see how that patient is doing. We can give education when the patient needs it. It's encrypted to abide with HIPAA regulations, and all we really need is a telephone line, broadband connection, air card. And we see it all over. We see it in offices, we see it in institutions, and it's fast growing in home care. This is Mercy's Virtual Care Center. This is a hospital. This is in Minnesota. This is the first virtual care center to be developed in our country. And this is a hospital, but there are no patients there. Clinicians, practitioners with computers doing telehealth. And I'll give you some examples of what they're doing there. So they go across about 4 or 5 states, and all of their hospitals are connected with them. And from what I hear, other hospitals are also contracting with them now too. So they do some great things. E-stroke is one of them. If a patient goes into a rural emergency room and there's no neurologist there, they will connect with means of telehealth, and that neurologist that they're connecting with will give the orders to reverse that stroke, because there's a time factor when somebody has a stroke and treatment needs to be given right away. E-sitting, this is another way they're using it. So sometimes patients need one-on-one observation. So what they could do with e-sitting is they're watching the patient. And if the patient says, if they see the patient getting out of bed and the patient's not supposed to get out of bed, they'll tell the patient, don't get out of bed, you're not supposed to get out of bed. Patient doesn't know where the voice is coming from, but they get back into bed. EICU. And EICU, we're beginning to see in our local health systems right here also. I believe in Nassau County, I'm not sure about Queens, but EICU is when we have professionals sitting at the computers watching the patients that are in ICU. They're not taking over for the doctors and nurses that are already in ICU. They're supplementing for them. They catch things earlier, so they can identify early signs of sepsis, early signs of anything that can cause a lot of trouble for that patient and have that patient deteriorate. So they've been seeing great results with this. We see telehealth also in mental health, for supportive services, for consultative services. So a patient can go to their primary care physician and they can get connected to a specialist through the use of telehealth. In home care, as I said, it's fast growing in home care. Nurses use it, therapists use it, and we use it for clinical management to help the patient self-manage their illness. So the advantages are that patients become more autonomous. They feel in more control of their illness. They're able to manage their illness better. Clinicians can also see more patients with the use of telehealth. It improves quality of life. We can also reduce or, reach underserved areas. So we can help decrease those healthcare disparities. So patients do need to have some manual dexterity and some vision and hearing to be able to work the technology, but if they have a caregiver that can help them, they can probably still utilize the technology. So this is a video patient station, and this is what we have up at our nursing lab that our students have access to, and this is what we see in some of our local health systems. And it's very easy for the patient to use. You see a camera here. This camera can be taken off and a patient can show us medication bottles, wounds, and we can do a video interaction visit. This is a stethoscope, and with the supervision of the clinician, patients will be instructed to place the stethoscope appropriately so we can listen to lung sounds, heart sounds, abdominal sounds. This right here, this will show up on the screen, this green button, and it will ring like a phone, and the patient just presses the green button, and then there's a connection between the clinician and the patient. These are some of the peripherals being used, and today it's all wireless. So years ago we saw with they were connected with the wires, but today it's all wireless. This is a pulse oximeter. This checks oxygen saturation and pulse. We have a scale, glucometer, blood pressure monitor, and these are just some of them. And these peripherals, the patients can utilize them, take their vital signs, and that information gets sent over to the clinician. So we can see how a patient's doing on a daily basis. And if a clinician is going to do a video interactive visit with that patient, we encourage patients to do this before the visit, so that will give information to the clinician and help guide the visit. And this just shows you how patients are taking their blood pressure and the instructions that come up, and it also narrates to the patient. And if for some reason it's not streaming into the computer, they can click on manual entry and put a manual entry in there. Here they can click on history and get a history of maybe their weights, and they can look at their weights and see that they're gaining weight from day to day. And what that does is it helps people to connect the dots, and they see, oh, I'm gaining weight. I ate more sodium yesterday, and I see now what's happening. That makes me retain fluid. So it gives them a sense of control over what's going on. And then here they click on daily sessions, and that will bring them to the instructions for the vital signs and the series of questions that they will be asked. So here we have a sample of some of the algorithms that we use, and we download to the patient's computer. So when they enter their computer, all those questions will come up. So if they have heart failure, we may ask questions about how is your breathing, how do you feel today? If they have diabetes, we may ask about signs and symptoms of hypo and hyperglycemia, low or high blood glucose. And this is the clinician at the computer. And to listen to lung sounds or heart sounds or abdominal sounds, there's a guide, and the patient gets one and the clinician gets one, so that they can guide them. And what they'll say is put the stethoscope on number 1, on number 2, on number 3, and guides them with that. And the sound is incredible. You can hear very clear sounds and hear lung sounds, heart sounds, and abdominal sounds. So the components of a telehealth visit are quite comprehensive. You can do a complete assessment and education, help patients to manage their symptoms and problem solve. This is the provider station. Here's the camera here. The patient area can be made larger. And this right here, you can see part of the electronic health record. And you can see where it's red. And what that's showing the clinician is that the patient may be out of the norms for safety for their vital signs or how they answered the questions. So if the clinician turns on the computer and has 20 patients, the ones that are in red will be priority because those vital signs were out of the norm. And that's preset by the clinician. This shows how good the pictures are, how clear they are, and how they can be utilized. So the camera is very good. This is another company that is working with telehealth, and they're working just with iPads. So it makes it a little bit more mobile now. So patients can be more mobile, clinicians can go with their iPads, and you can connect almost anywhere. The only thing is they don't have the stethoscope yet, and I think they're working on that so that it can be a complete visit. So some patients, though, may like the one that's on the base, and some patients may like to be more mobile with an iPad. So there are some legal and ethical issues. We want to make sure that the technology doesn't replace quality care, that it's a supplement. So we want to make sure that professionals focus on the patient and not the technology, and use the technology as a medium to help patients manage their illnesses. There are organizations that put out standards of care for telehealth, so there are standards and guidelines of care for this as well. I'm going to show you a quick video of how patients feel about using telehealth.
I don't know what we'd have done without it. It has helped us so much.
With this machine and different things, it really improves me. It helps me a lot.
And it helps monitor their vital signs and helps monitor their health status, and they answer some questions on the devices. And all of that information is downloaded on a daily basis to a nurse who evaluates it. And the hope is that if there's a problem, it can be identified sooner so that the patient doesn't end up in the hospital or emergency room. Instead, the nurse or their physician can intervene.
Our theory was that if we were to watch on a daily basis, we could see negative trends occurring. We could intervene with teaching, with patient education, turn those negative trends around, thereby avoiding hospitalizations, emergency room visits, and keeping the person at home.
Inside this website, we set parameters or values for each measurement. If the measurement is not within parameters, it will come up in red. We have surveys. They're either information, education, assessment questions. If we have a survey set up attached to a measurement, then if that measurement is out of bounds, it automatically sends that survey back.
And it's a blessing to us because it was a hardship for us to get up and go out in the weather and everything.
And by taking my blood pressure here like I do, it makes me more alert to eat right, take my medicine, and everything.
Most of these people that had 1, 2, or 3 hospitalizations before we put the equipment in the home have maybe 1 or none, within a year's time after having the equipment in the home. And that's because they're getting intervention before they have to go to the hospital.
We have been able to assist persons staying in their homes successfully.
Home is where they want to be. Home is where they should be allowed to be. And home is where we're keeping them.
Clients tell us that they feel now empowered.
So it really can be a beneficial service not only for the patients and for the caregivers, but for the health system as a whole.
Seniors want to be home as long as possible. Telehealth allows that to happen.
This is the best thing that has ever happened to us. And I really mean this from my heart. Today, I wouldn't be where I'm at today if it wasn't for this right here helping us.
So in conclusion, our healthcare system is doing a lot to improve clinical outcomes and decrease cost, and when they do that, we feel the benefits from that. But also, we need to take an active role in our own health. It's never too late to start, it's never too early to start, and through an active partnership With a healthcare system, individuals, communities, we can create a healthier nation and healthy people. I would like to thank all of you for being here today, and I'm open to any questions you may have.
Hi, Professor. I have a question regarding the telehealth. Is it covered by insurance companies, the equipment and the visits? And if so, is there a criteria for it?
That's a good question. I'm sorry? Which one is it covered by? So telehealth, it depends on where it is, what site it's at, and what discipline is using it. So it is covered for like consultation through physicians, nurse practitioners. It is not covered in home care though. So home care gets paid by an episodic payment, and they decide how to best service the patient. So they'll give the patient if they need it though. So home cares will give it to patients if they need it, if they're on home care. But it's not covered by insurances on home care.
That's terrible. I don't have it in New York yet, or that's a shame.
Yeah, there are, some insurance companies also work with patients too, though, and I think at very low cost, or maybe sometimes they even give it to patients, because it will keep patients healthy and keep them out of the hospital. So it really will depend on the particular insurance. Yeah.
Sorry. I think healthcare is a very important factor in rural areas because a lot of them don't have doctors for like 30 miles, and this so they can keep in contact with a doctor when they get sick. It's going to be very important in very small rural areas. And what is your elaboration on that?
I'm sorry, I didn't hear the last part of that.
What is your elaboration on that?
Oh, in the rural areas, it's very helpful in the rural areas because just like you said, they may have to go miles before they can get anywhere. So we've seen great outcomes with that, especially like with e-stroke. So some patients have a very small rural hospital and they don't have the resources at that hospital, but they can connect by means of telehealth.
Some people may even be near a hospital. They're so far away, they're so rural area. So they might have to go to a doctor in an emergency where you have to get a hold of them,
Yeah, I don't know if you saw the commercials recently also, they have televisits by doctors through iPads now as well.
Good.
Mm-hmm. Yeah, telehealth is really exploding across our country.
Good.
Mm-hmm.
One question I have, are they using telehealth more in rural settings or in the city or both, or what's the intention?
Both. They're using it in all areas. We see it here in Queens, we see it in Long Island, we see it in the rural areas, so they're really using it not only for access to patients that can't get to services, but also to help patients self-manage their illnesses. So regardless if they're in a rural area or an urban area, it's going to help patients with their clinical management.
I just have a practical question, which is, how would you put the stethoscope to all those places?
That's a good question. Yeah, so they need a caregiver. You need someone to help you with that. Otherwise, it would be really hard because a patient may be able to, or anybody may be able to get to the lower back, but it wouldn't get to all the lobes of the lungs, and we really want to know how all the lobes are doing. So a caregiver is really needed for that. Yeah, that's a good question.
I have a question, but it's not related to telehealth. When patients stay in the hospital for a very long period of time, they end up picking up, bacterial infections. And in a setting where it appears to be completely pristine, everybody wears gloves, apron, everything, and yet the patients get infected with some kind of bacteria, which is totally not related to, what they came into the hospital in the first place. A, I don't know the reason why. B, what can we do to eradicate this really major problem in hospitals?
I'm sorry, just say the last part of that
question. What can we do to eradicate, to get rid of this problem?
Yeah. Well, discharging patients quicker is one thing, and that's what they are trying to do, is get the patients out of the hospital as soon as they can. And for us, you know, just making sure health professionals are washing their hands in between patients, and also we're washing our hands. I mean, that's one of the major factors is hand washing. Yeah.
Thank you, Professor Rosa. I think, and really, you're right.
Thank you. Thank you.
You may get a glimpse as to why the students who complete our nursing program pass the NCLEX, that RN exam at the state level, at a higher rate than our senior college sisters, including Hunter. And it's because of faculty such as Professor Rosa and many of my colleagues in the audience. So I do applaud. And I thank the committee, Dr. Van Els, I see you're here, and he's been long requesting that we really address this particular topic. So thank you, because I think I enjoyed it, and I hope you did as well. I invite you all to have a bit of refreshment, and then we will send you an invitation to our fall series, which features usually a CUNY faculty member who can speak on topics related to all the things that we do in our great university. So thank you, Professor Rosa.